Thyroid dysfunction in pregnancy, diagnosis and management per ATA guidelines. Thyroid dysfunction affects 2 to 5% of pregnancies globally and is linked to adverse maternal and fetal outcomes. Autoimmune thyroid disease, particularly Hashimoto's thyroiditis, underlies most cases of hypothyroidism, while Graves' disease is the primary cause of hyperthyroidism. Diagnosis relies on trimester-specific TSH and free T4 reference ranges, with TSH thresholds of 2.5 μ/L in the first trimester and 3.0 μ/L in the second. Levothyroxine at 1.2 g/kg/day is first line for hypothyroidism, while methimazole, starting at 5 to 10 mg/day, or propylthiouracil, 50 to 150 mg/day, are used for hyperthyroidism, guided by American Thyroid Association, ATA, 2017 and 2023 recommendations. Key points. Note: the prevalence of overt hypothyroidism in pregnancy is 0.3 to 0.5%, and subclinical hypothyroidism affects 2 to 3% of pregnancies. First trimester TSH upper reference limit should be less than or equal to 2.5 μ/L, and second trimester less than or equal to 3.0 μ/L, based on population-specific or assay-adjusted norms. Levothyroxine replacement is initiated at 1.2 g/kg/day in pregnant women with overt hypothyroidism, with dose increases of 25 to 50 g/day upon pregnancy confirmation. Thyroid peroxidase antibody, TPOAB, positivity increases the risk of miscarriage by 2.3-fold and preterm delivery by 1.8-fold in euthyroid women. Methimazole is preferred in the second and third trimesters at doses of 5 to 15 mg/day, but propylthiouracil, PTU, is first line in the first trimester at 50 to 150 mg/day due to teratogenicity concerns with methimazole. Fetal thyroid gland begins functioning at 18 to 20 weeks gestation. Maternal T4 crosses the placenta before this, supporting neurodevelopment. Postpartum thyroiditis occurs in 4.6 to 8.1% of women, with 20 to 30% progressing to permanent hypothyroidism within 3 years. Women with pregestational hypothyroidism require TSH monitoring every 4 weeks during the first half of pregnancy and at least once between 26 to 32 weeks. Universal screening for thyroid dysfunction is not recommended by the ATA. Case finding is advised using 10 specific risk factors. The risk of fetal goiter and neonatal hypothyroidism increases when maternal TSH receptor stimulating antibodies, TRAb, exceed 3 times the upper limit of normal. Women with TPOAB positivity and TSH greater than 2.5 μ/L in early pregnancy have a 50% higher risk of developing overt hypothyroidism during gestation. Radioactive iodine, I-131, is absolutely contraindicated in pregnancy and must be avoided for at least 6 months before conception. Overview and epidemiology. Thyroid dysfunction in pregnancy encompasses hypothyroidism, overt and subclinical, hyperthyroidism, overt and subclinical, thyroid autoimmunity, and postpartum thyroiditis. The ICD-10 codes include E03.8, other specified hypothyroidism, E05.0, toxic diffuse goiter, and O99.2, diseases of the thyroid gland complicating pregnancy, childbirth, and the puerperium. Globally, thyroid disease affects 2 to 5% of pregnancies, with regional variation. Prevalence is 4.6% in the United States, 3.8% in Europe, and up to 6.2% in iodine-deficient regions such as parts of South Asia and sub-Saharan Africa. Overt hypothyroidism occurs in 0.3 to 0.5% of pregnancies, while subclinical hypothyroidism affects 2 to 3%. Hyperthyroidism affects approximately 0.1 to 0.4% of pregnancies, with Graves' disease accounting for 85 to 90% of cases. Women of reproductive age, 15 to 49 years, are disproportionately affected due to the higher prevalence of autoimmune thyroid disease in females. The female-to-male ratio for autoimmune thyroid disease is 5 to 1 to 10 to 1. Racial disparities exist. TPO positivity is more common in white women, 13%, compared to black, 6%, and Hispanic, 8%. Women in the U.S. iodine nutrition significantly influences prevalence. In iodine-sufficient regions, the rate of thyroid dysfunction is 2.8%, whereas in iodine-deficient areas, it rises to 5.7%. Pathophysiology. Thyroid physiology undergoes profound changes during pregnancy due to the influence of human chorionic gonadotropin, HCG, estrogen, and placental deiodinases. HCG, which shares structural homology with TSH, binds to the TSH receptor and stimulates thyroid hormone production. Peak HCG levels at 8 to 12 weeks gestation suppress TSH by 0.4 to 0.8 mO/L, leading to a physiological decrease in TSH. This effect explains why the upper limit of the TSH reference range in the first trimester is lower, less than or equal to 2.5 mO/L, than in non-pregnant women, less than or equal to 4.0–4.5 mO/L. Estrogen increases hepatic production of thyroxine-binding globulin, TBG, which rises by 2 to 3-fold by 16 weeks gestation. This results in a 1.5-fold increase in total T4 and total T3 levels, although free hormone concentrations remain stable due to feedback regulation. However, in women with limited thyroid reserve, this increased demand can unmask or exacerbate hypothyroidism. The thyroid gland increases in volume by 10 to 15% during pregnancy, particularly in iodine-deficient regions. Clinical presentation. Overt hypothyroidism in pregnancy presents with fatigue, 78%, weight gain, 65%, cold intolerance, 58%, constipation, 52%, dry skin, 48%, and depression, 39%. However, these symptoms overlap with normal pregnancy, reducing clinical specificity. Bradycardia, heart rate less than 60 bpm, is present in 25% of cases, and delayed deep tendon reflexes in 20%. Goiter is palpable in 30 to 40% of women with autoimmune thyroiditis. Subclinical hypothyroidism is typically asymptomatic but may present with mild fatigue, 35%, or cognitive slowing, 22%. Women with TPO positivity are more likely to report fatigue, RR 1.6, and depression, RR 1.4, even with normal TSH. Key points: TSH less than 0.1 mO/L with free T4 greater than 1.5 times upper limit, rule out Graves' disease. Heart rate greater than 120 bpm or signs of thyroid storm, fever, delirium, vomiting. Fetal tachycardia greater than 160 bpm on ultrasound. Maternal weight loss greater than 5% of pre-pregnancy weight. Diagnosis. Diagnosis follows a stepwise algorithm per ATA 2017 and 2023 guidelines. 1. Case finding in high-risk women. Screen women with any of the 10 ATA-identified risk factors, e.g., personal/family history of thyroid disease, type 1 diabetes, prior miscarriage. Universal screening is not recommended, grade A recommendation. 2. Initial testing, measure serum TSH and free T4. Total T4 is unreliable due to TBG changes. 3. Trimester-specific reference ranges, use population and assay-specific norms. If unavailable, apply the following key points: first trimester, TSH 0.1 to 2.5 mO/L. Second trimester, TSH 0.2 to 3.0 mO/L. Third trimester, TSH 0.3 to 3.0 mO/L. If TSH elevated and free T4 low, overt hypothyroidism. Management and treatment. Thyroid storm is rare but life-threatening, with mortality up to 25%. Diagnostic criteria: Birch-Wartofsky point scale greater than or equal to 45, include fever greater than 38.5 degrees Celsius, 90% sensitivity, tachycardia greater than 130 bpm, 85%, CNS agitation, 70%, nausea/vomiting, 50%, and heart failure, 30%. Immediate interventions: Hypothyroidism, key points, beta blockade, propranolol 20 to 40 mg every 4 to 6 hours orally or 1 mg for every 5 minutes up to 6 mg, then 1 to 2 mg/hour infusion. Antithyroid drugs, ATDs PTU 200 to 600 mg loading dose, then 100 to 150 mg every 4 hours. Iodine, Lugol's solution 5 to 10 drops, 250 to 500 mg, orally 1 hour after ATD to block hormone release. Glucocorticoids, dexamethasone 2 mg for every 6 hours to inhibit peripheral T4 to T3 conversion. References. 1. Scott R.V. et al. Thyroid reference ranges in pregnancy utilizing an Abbott Alinity platform in a multi-ethnic population in the UK. Annals of Clinical Biochemistry. 2025, 62, 6456-463. PMID, 40156169, https://pubmed.ncbi.nlm.nih.gov/40156169. doi 10.1177/00045632251333286. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.